Well, hello. Welcome to a lecture on the lungs. I'm going to make it a two-parter. So I'll go through some review of anatomy and physiology, and then we'll get into some infectious problems. Talk about pneumonia and TB, some big ones. All right, let's do it. All right, well, when we've done the heart, now look at the lungs. Two big killers and important in pathophysiology, of course. So first of all, to review, we ventilate our lungs, and it's a tidal flow. It's like the tides come in and out. It's not the most efficient because you always have dead air in your lungs, but we keep bringing in fresh air as long as it keeps the concentration of oxygen in the alveoli higher than the blood. And the concentration of carbon dioxide, because we blow it out, lower in the alveoli than in the blood, diffusion will happen. So we have this inefficient tidal flow. Birds actually, that goes through the lungs once, but we have it back and forth. But it works and allows us to have this exchange. And the surface area, because of all these millions of alveoli, you're going to see is actually half of a tennis court, in area. So we have this huge amount of area where air and blood are right next to each other, so diffusion can happen. Diffusion, there we go. So it's not an active process, it's just a passive process that allows us to exchange gases like this. Yeah. And you can also measure in the breath things like alcohol. And if you're diabetic, sometimes it's a fruity smell because of acetone. So other gases will come out, anything that's soluble in the blood. The term perfusion, we want to make sure that our organs and our tissues are perfused. That means there's enough blood flowing through the capillaries to deliver said gases. Basically, you guys, I'm not going to spend too much time, but your trachea comes down. It's going to split into the main bronchi, which will give you then lobar or secondary bronchi. Remember, we have 2 lobes in the left and 3 in the right. And so those secondary lobar will split into tertiary. It goes into little tiny bronchioles and eventually to the alveoli. So it's like an upside down tree indeed. And what causes us to breathe, we're negative pressure breathers. If need be, in a hospital situation, you can use positive pressure where you push on that bag and force air into the lungs. But we don't do that. We make a vacuum, mostly by our diaphragm, this dome muscle. There could be other chest muscles that could be involved that make the cavity bigger. And because the surface of the lung has that parietal pleura on it, visceral pleura on the surface of the lung, it sticks to the parietal pleura, which lines our cavities because there's a wetness there, and the lungs expand. And breathing in actually takes the work. Breathing out is almost passive because you've stretched the lung, the elastic fibers, and they just want to snap back like a rubber band. The alveoli, it's not actually spherical. They're more like polyhedrons. They're little circular, and they would tend to collapse because it's a moist surface, but we're going to see we have a chemical in there that keeps them from sticking to each other. Millions per lung, nice healthy lung. We'll see as you have lung degradation and emphysema and such, those beautiful, delicate little alveoli will coalesce and make these big spaces, which is no good. And you look at the gross anatomy of a lung, it looks like a sponge or a Nerf football you've cut through, but there's a little microscopic alveoli in there. And all this surface area has to be wet for gases to dissolve in it, and then the blood has to be right below it, right below it. The distance has to be very small for gases to diffuse. We'll talk about the cells in your alveoli. Most of them are these type 1 pneumocytes, another name for lung cells here. And they're just squamous cells, super, super thin. The type 2 pneumocytes will be found in the nooks and crannies, and we're going to see they're going to be secreting, remember they secrete surfactant. So you look at histology of a lung, gorgeous, has all these little air spaces, and you'll see blood vessels going through it and bronchioles going through it for the air and the blood. And in these walls here, there's going to be capillaries, little tiny capillaries there, yeah. So this membrane, the respiratory membrane, is so important that that's healthy, and it has to be as thin as possible. So you have on the blood vessel side, the capillary side, you've got the endothelium of the capillary. Then you have a little tiny bit of connective tissue, those basement membranes from both the endothelium of the capillary and the pneumocyte, super flat squamous cell of the pneumocyte. And that's all you want, this tiny, this really narrow membrane between blood and air so that this gas exchange takes place. And then the cells, the type 2 cells are making surfactant, which we'll talk more about in a moment. Yep. And then zooming around through all the alveoli will be macrophages, alveolar macrophages. And they're going to consume dust particles, tar from smoking, any bacteria gets down in there, asbestos, or anything that gets down deep in your alveoli, the macrophages will clean up. You put a bunch of lymph nodes too, where the bronchi come into the lung, a whole bunch of tracheobronchial lymph nodes. And you'll see they're often black in smokers. They've just been accumulating all the debris from the lungs. So this surfactant, yes, it's a lipid-rich molecule that is going to reduce the surface tension in your alveoli so they don't stick together. And this is the key reason why preemies, premature infants, don't make it, is because they have, the first thing we'll talk about is this respiratory distress syndrome, where if you're born premature, your lungs aren't making surfactant, and the alveoli will collapse. And then you'll have infections, all kinds of bad things. So that's what keeps you from being born too early, really, is your lungs aren't mature. Your kidneys are working, your liver's working, your heart is working, but it's those the lungs that have to work as soon as you're born. Looking at this, there's elastic fibers that are all over the place. So your lungs are very elastic. And as you breathe in, you inhale, those elastic fibers are stretched, and then passively they come back. Much like in our blood vessels, in your aorta, as the systolic pressure comes in, your blood vessels expand, the elastic fibers expand, and then they release that energy in your diastole before they're stretched again. And so the lungs being elastic, we talk about a property called compliance. You want the lungs to expand and then come back again. You can imagine if they don't, you're gonna have problems. Now, up in your trachea and your bronchi, you have this mucus elevator, or mucociliary elevator. And that epithelium has cilia on it, and scattered throughout are goblet cells that make the mucus. And so in a normal person, in their nasal cavities, down their trachea and the big bronchi, is all this wet mucus, sticky mucus that captures the dust, the bacteria, anything trying to get in. It sticks to the mucus, and then the cilia are beating the mucus, so they go up, and then you cough and swallow it, or it's brought back in the nasal cavity to be swallowed. So that's the way we clean things out. And smokers, that paralyzes those cilia and actually destroys the ciliate cells and makes it squamous cells. And that's why they cough a lot. That's another way to get rid of the mucus, is to cough it up, where it's much more, takes a lot more effort to do that, and it's not as effective, right? So yeah, so this mucus and cilia are so important in a healthy person to cleaning out the lungs, anything that gets in there, small particles. Now, you don't think about the lungs, you think, oh, oxygen, carbon dioxide, but it's so important. It's the most important way we can affect our acid and base balance. And in your body, you need to keep it between 7.35 and 7.45. So is it acidic? No, it's slightly alkaline. And if you go too low, you become acidotic. If it goes above 7.45, you have alkalosis. And as you read a lot of diets, how, oh, you're gonna, you're too acidic, and so you need to make your body change your body pH, and it's a bunch of crap, really. And they'll talk about, oh, take this alkaline water. It's always good with a squeeze of lime, right? It adds acidity. It completely neutralizes it. But people listen to this and they'll buy their books and products. So anyway, your body takes care of your acid-base balance through buffers. And the most important thing is your lungs, is carbon dioxide. Yeah. And the deal is, how do we keep it just there? It's through buffers. Just like in chemistry, you add buffers to a test tube to keep the pH right. Because if your pH is off, you're going to die. If it gets too high, too low, you die. It's fatal. Right? It has to be in this narrow range. And carbon dioxide is the main culprit here. As you have carbon dioxide building up, carbon dioxide binds with water to make carbonic acid. We have you guys know the enzyme that really speeds that up? Carbonic anhydrase. So it's found in your blood cells and everywhere. This carbonic acid can easily lose a hydrogen ion and turn into bicarbonate ions. So when you look at, very, very important, you look at a blood workup is, bicarbonate ions. You can pee these out. But if you have too much acidity, what happens is that it shifts this way. And bicarbonate takes up the hydrogen ion, takes the acid out of the solution and stores it here. And it can go the other direction too. So that's what a buffer does. It's going to shift it to keep your pH correct. And the most important by far in your body, super important, is this carbon dioxide binds with water to make carbonic acid, which dissociates into bicarbonate and hydrogen ions. And this can shift. The direction can go either way with this reaction. Thus, it's a nice buffer. And so the most easiest way to become acidotic is to hold your breath. You hold your breath. Already, my pH is dropping and becoming more acidic that quickly, because as carbon dioxide is bubbles out of all my cells as I break down sugars, that carbon dioxide turns into acid. And if you hyperventilate, you get rid of more carbon dioxide, you become more, the pH becomes higher, you become more alkaline. So this respiratory alkalosis or acidosis is the easiest way that we shift our pH. Metabolic has to do with kidneys and other things like that. If you're vomiting a lot, you actually become alkalosis because you get rid of a bunch of hydrogen ions, the acidity of your stomach pH, and there's other things too. But so we look at our kidneys and our lungs for determining our acid-base balance. And your lungs are much quicker than your kidneys. It takes much longer to get rid of hydrogen ions in your kidneys than simply ventilating. And where do we determine our pH? And what determines our breathing? Again, I'm reviewing A&P. I got to move on, but it's not like your oxygen levels. That's a way back up. If you're really low on oxygen, you have a real pathological condition, your oxygen levels will kick up your breathing. But normally, it's not even involved in day-to-day life. It's your CO2 and acidity. And your cerebrospinal fluid, in your brain, the brain stem, you're always measuring the hydrogen ions. And if they build up, you're becoming acidotic. Your breathing region in your pons and medulla say, hey, breathe more rapidly and more deeply. All right? And if you have hyperventilated, you notice your breathing stops. So it says, okay, slow down. So that's what's doing your breathing rate, is carbon dioxide and acidity. All right, so I think I've talked about this. If you become acidotic, you'll have headache and drowsiness. If you're too alkaline, also lightheadedness and fainting, things like that, definitely. And what causes acidosis? Usually either you're being strangulated, there's something blocking your breathing, or there's lung diseases. Yeah, and your body reacts by trying to breathe faster, making more red blood cells, right? Because it's just low oxygen levels. It does what it can to try to bring that up. Sleep apnea, you stop breathing at night, definitely. Some drugs. Alkalosis, if you hyperventilate, it's the main thing. Caused by anxiety sometimes too. Yeah, and so when we look at the world of lung diseases, we talk about restrictive and obstructive. I think you know what obstructive is. There's some obstruction in your tubes. But restrictive can be a couple things. One, it can be in your pleural cavity. You can fill with air or blood or fluids, and it doesn't allow the lung to expand. Or there's issues with the lung tissue where the elastic fibers, or there's just fibrous fibroids in there that it doesn't allow it to expand either. That's restrictive lung disease. Obstructive, I think you know, is asthma, COPD. Either the muscles are constricting your bronchioles and tubes, or they're filled with mucus, or both, thus making the tube smaller. So in this kind of easy diagram, you can see your lung is like a balloon. It should be elastic and flexible. It should push the air out, but you've got a tube problem. Your tubes are small. Can you imagine trying to suck air through a little tiny cocktail straw versus a bigger straw? Much more resistance, much more difficult. And then the other thing here, looking at it, could be, in this case, the tubes are fine, but the lung is no longer elastic. You have this paper bag. So air is not pushed out because of elasticity. Yeah. Some more terms for you. Atelectasis is a collapsed lung. And usually, I mean, if you have some kind of stab wound, puncture in the lung, even the neck gets into the pleural cavity, and that air comes in, it doesn't allow the lung will just collapse into the elasticity collapses it. I'm sure I gotta step inside because it is raining. Yes. Or you can see atelectasis when you have a blockage of a bronchi, and the air beyond that blockage gets absorbed. Yeah, but then the blockage is going to keep the lung collapsed. Bronchiectasis, I can say that, is when you have an obstruction. And then you imagine that you have a bronchial obstruction. So this part of the lung, the mucus can't drain. So there you get everything is trapped in there, and then an infection can happen. And so you have an area beyond the bronchi, big or small, that nothing can escape. And if the air has been taken out of that area, then it's gonna collapse at that point. And you'll hear consolidations. I was reading things about COVID, and you can see consolidations. What that happens is that in the alveoli, you have an accumulation of neutrophils and pus and debris from the inflammatory response. And it can be cancer cells can fill it up too. But it's when you take air spaces and you fill it up with material, and you can see that on an X-ray. Oh, there's a cool X-ray here. You can see some fluid building up. We'll talk about when pus leaks out of the lungs too, and it fills up the pleural cavity, preventing proper filling of the lungs. Here, showing atelectasis. And here, imagine you have a puncture, and it's going to cause the lung can no longer inflate because it normally wants to be deflated, the elastic fiber. It needs to be stuck by that wet membranes in order to inflate. And if you puncture it, you don't no longer have that airtight area, and air just comes in this way instead of coming in through the mouth or nose. Indeed. And so what you do this, of course, is come in there, take suction, suck the air out, and then plug the hole up, and then you can regain that. And you'll see you can have one collapsed lung and not the other. Collapsed lung, you'll see the trachea deviates to the side. You can tell which lung is collapsed. And normally if you suck out that air, you can fix this problem. And here it is because of a bronchial obstruction. Imagine this was obstructed. And then what happens is that the air, the gases get absorbed into the blood, and then it's going to suck away from the membrane. Well, looking at lung diseases, the main cause is smoking. So I'll talk about smoking here for a bit. But not only is it lung cancer, but it's an emphysema. Those come to mind right away. But bladder cancer, kidney cancer, diabetes problems, healing problems, low birth weight in kids. I mean, coronary artery disease. They've shown that when they stop public smoking, that in an area that there's less heart attacks. So, it's just a huge drain, estimated 157 billion, more people die per year smoking that, we talk about huge deaths like 9/11, 3,000-4,000 people. This is 500,000 people. Yeah, we don't think, nothing can be done about it. Well, and this is one of these things I talked early on, how the Surgeon General's report came out in 1964. That was before I was born, not long before, but came out saying, oh, there's health risks with smoking. Before doctors would claim, oh, it's healthy to smoke. And then in 2014, another report came out from the Surgeon General, just adding on to this huge amount of evidence that there's nothing you can do to make yourself healthier than to quit smoking, right? And if you look, it's going down overall. This is from 1965 to 2000, and it keeps going down. You see, originally more men smoked. It wasn't considered ladylike to smoke, and that gap closed. You can see, and not completely. Going down, which is good. But of course, tobacco companies then they're losing business, so they export it to other countries. And some Asian countries in Eastern Europe, 70% of men smoke. It's just and there's a time lag between this smoking and when the cancers come about. And so we're going to see why cancer is going to overtake, heart disease and such. And socioeconomic factors, interesting. I had a ex-girlfriend who worked as a bartender, and it's hard in the service industry when people go on their smoke breaks, and so no one starts smoking going, oh my God, that smoke was delicious, give me another. No, you cough, it's a horrible headache, right? But you become addicted to the nicotine. It changes your brain, and so that's what does it. So that beginning smoking happens in the teens. Like, cigarette companies can't get you to start when you're like 25 or 30. They need to get you when you're young, and there's peer pressure, and you want to be cool and smoke, and so they got to do that. And looking at income, you can see that, if you make a lot of money, you're much less likely to smoke than if you make fewer money. And cigarettes are expensive, and so the people that can't afford to get cigarettes are the ones buying them. So it's kind of sad. Interesting looking at education. You guys get education, but look at the huge difference here. You can see between having a college education and then grad school, like 6% smoking, as opposed to 30% without a high school education. So these are just, I can't get interesting socioeconomic factors that contribute to smoking. And the things in red were new in the 2014 report. So, we always knew all these cancers, and we added a couple more, and you can see erectile dysfunction, immune health. If you're going to get some elective diseases, gastric bypass, if you're a smoker, they won't give it to you. Because why would we waste our time if you're not going to heal properly? So, and secondhand smoke, of course, very, very dangerous. You can see non-smokers. You work in a bar where they smoke, you're at a 20-30% greater risk of lung cancer. So that's why public bans are so important. It's not about controlling you. It's about the people that need to have those jobs that are forced to be in that environment. They should not be forced to get lung cancer. And I remember growing up, my mom would light a cigarette in the car and crack the window. It does a lot, right? And I remember that first smell. I think it's the paper burning something would just give me a headache. I remember this from my childhood. It's horribly addictive. I remember asking my mom long after she had quit, decades when she was much older, do you still think about smoking? Because she didn't smoke anymore. Isn't it good? Like, you don't think about smoking? She says, Jeff, every day. So it's powerful and difficult to quit. I definitely know this. And you all have people in your life, I'm sure, that try to quit. So it's insidious. Addiction changes your brain chemistry. And then you guys being health professionals know that smoking, secondhand smoke in children causes they're going to be sicker more often. And smokers are sicker with respiratory infections more often. They have more colds, more flu, because that mucociliary elevator is damaged and they can't get rid of the bacteria that a healthy person could. All right, and I put this in just for A&P this last semester, vaping, because it's increased 900%. So all the people that make vapes, all the cigarette companies also make vapes. So, you want quit smoking? We got this for you. They've got the alternative all ready for you, right? And the thing is, we just don't know enough. It's too new. So I would say it's probably better than smoking. How's that? But it's just another way to get you addicted to nicotine. And there's nicotine-free formulas, but it's another way to get kids hooked, and it's absolutely geared towards teens, because that's when you need to get them. Once you're an adult, it's too late to get. No one starts smoking, as an adult. Few people. All right, and lastly, again, if you're a smoker, hopefully this got you to quit. But more than just, if you look at just the appearance, and the best way is identical twin studies. You get twins that have the same genetics, and then one smokes and one doesn't. You find these people, you can see a big difference looking at hair, skin. It ages you just much quicker. And Remember neoplasms? What happens is that it ratchets it up the mutations before it becomes cancerous. So quitting smoking does stop that process. But we'll see that emphysema, some of these lung diseases are irreversible. The damage is done, it does not heal. All right. Lung cancer. You guys know it's one of the ones you don't want to hear. It's one of the, has the greatest mortality. So lung cancer. And that lag, interestingly, we're looking at now lung cancer rates. We need to look back, back 70s and 80s to look when these people started smoking. We'll talk about how you calculate pack years and stuff, but lung cancer, yeah, not a good one at all. And then we'll talk about pneumonia today, bacteria, virus infections of the lungs. Pneumonitis is going to be, it's like pneumonia, but it's not infection in the air spaces in the lungs, but in the walls of the alveoli. So yeah, we'll talk about that. And then biggies here, we'll do this next lecture, COPD, chronic obstructive pulmonary disease. We're going to see it's emphysema, which just breaks down the alveoli, makes these air pockets in your lungs, and chronic bronchitis, narrowing those things. Some people that don't smoke get this, but it's pretty rare. It's smokers, and this is a huge cause of death and morbidity, COPD. And then asthma. Some of you out there probably have asthma. This is I'll talk about what's chronic inflammation caused by some trigger, some overreaction of your immune system, interestingly. And we'll talk more about it, but this is reversible. Unlike COPD, asthma, you can take bronchodilators or remove the allergen and you go back. All right, chronic bronchitis, you've destroyed the bronchi. And asthma usually when you're younger, whereas COPD is from years of smoking. All right, we'll talk about a genetic disease, cystic fibrosis, and I'll hold off talking a lot about it, but look at most common genetic disease in the white population. And you end up with tons of mucus in your tubes, and it's hard to get rid of. And when you have a lot of mucus, bacteria grow in there, you get lots of pneumonia, and that destroys your lung chronically if you keep having pneumonia forever. All right, so person comes in. Let's talk about some tests that we can do. First thing is you can notice their breathing. You can listen to their breathing. Dyspnea, difficulty breathing. Apnea, not breathing, all right? A, without. You talk about sleep apnea is when you during your sleep, you stop breathing throughout your sleep. Orthopnea is when it has to do with your position. You guys know if you had trouble breathing, would it be better to lay down or to stand or sit up? Don't lay down, because then all your guts tend to push up against your diaphragm, and your diaphragm has to push against that. If you sit up, your guts sag, and it's easier to breathe. So people with this, they often need to sleep sitting up in a chair or in a hospital bed, because it's really hard to breathe when they lay down. If to be tachypnic means you're breathing too rapidly, like tachycardia is too rapid a heartbeat. Usually this comes about because you're trying to compensate for not enough oxygen. Somnolence, interestingly, yeah, it shows us it can be caused by low carbon dioxide levels. This is when you have the feeling, the need, you want to sleep, when you're tired. In carbon dioxide narcosis, if you have too high levels of carbon dioxide, you actually can become narcosis. You can lose the ability to think clearly and such. So something to think about. If you're hypoxemia, you're going to have low blood oxygen. If you're hypercapnic, too high carbon dioxide levels. And then when you listen, wheezing, everyone knows what wheezing is. And rails are, you hear the kind of crackles when you're there. As you breathe, the water, the fluid is going to like kind of be turbulent. Coughing, let me tell you, it's pretty easy. Coughing is a sign that you are trying to clear something from your airways. And you have nerves, especially in your carina, where the Trachea splits, a lot of nerves there. Where the splits are, a lot of nerves. So if you aspirate something, you cough violently to try to get rid of it, right? And like I say, smokers will cough more because they need to get rid of that mucus because the little cilia aren't working to get rid of it for them. Sputum. Nurses, you're going to be familiar with sputum. Get a sputum collection. What does your sputum look like? You know, it's disgusting talking about, is it yellow? Is it red? Is it just clear? But it gives you an idea, you know, how purulent, how much pus, how yellow it is what kind of infection's going on. And you can collect it and do cultures to see what's growing in there. Yeah. Blood, of course, if you have anything hemo is blood, hemoptysis is when there's blood coming up. Good sign something's wrong. I've talked about cyanosis. If you're cyanotic, you are blue. It happens in newborns if you have a congenital heart defect where there's mixing of blood, not enough oxygenation. If you're very cold, you become cyanotic too. If the blood is moving slowly, your lips or nail beds can become blue because the blood's moving so slowly, oxygen's been drawn out of it. But obviously, with a lung issue where you can't oxygenate, you can become cyanotic. Well, one way to find out about what's going on in the lungs is through tapping, percussion. The details, you can learn more about it, but when you listen and you have experience with this, you can see it should sound resonant, like you're tapping on a guitar, and you can tell it's filled with air in there, right? If you filled the guitar with water and tapped on it, it would sound different, yeah. But hyperresonant might mean that there's air. Pneumothorax means air in the lungs. You have a collapsed lung. If it sounds too dull, there could be pleural effusion or water in there. So yeah, as you tap on the lungs, you can find areas where you may feel even there's a tumor in there. It's going to sound different just by tapping. Quick way to do that. And listening with the stethoscope. You know, take a breath and you can listen to see what's going on. You may hear those wheezes and rails, the crackling in there that tell you that the tubes have fluid in them, and so you're wheezing to get the fluid by it, or the fluid is bubbling up as you breathe. All right, well, some measures, you guys, from A&P, hopefully at a lab where you did spirometry, right? Spirometer, various kinds, can measure your vital capacity, your tidal volumes, your volumes in your lungs, and also lung function. You know, what's the peak flow? How fast can you breathe in or out? All right, there's an old-fashioned one. So real quickly, you guys remember, your normal breathing in and out is called your tidal volume. It's about half a liter to normal breathing in and out, but you have the capacity to really breathe in. That's your inspiratory reserve. You have that reserve, and you breathe out. You can breathe out additionally your expiratory reserve. And if you took the biggest breath in and breathe all the way out, we call that your vital capacity. Now, it's really important when you're doing these tests, that effort, because you can always get a lower than normal result, but you can't get a higher than normal. I can't fake it and get more lung air in my lungs. But if you're half-assing the test, you can easily get less, you know. Not that you guys in lab would do that. I mean, but yeah, so you really want to give encouragement. You want to get biggest breath in, biggest breath out, so you get a true measure of their vital capacity. And even after you breathe out as much as you can, you guys know there's always dead air in your lungs, that residual volume that you can't get rid of. So if you were able to measure that residual volume, add it to the vital capacity, you would get the true measure of how much air your lungs can hold, the total lung capacity. All right, good review. You guys got it? And so you can measure various, like follow someone's vital capacity throughout, if they have a lung disease, to see how it gets worse and worse through time. And lung function is not just measuring these volumes, but measuring how fast can you get rid of that air. You're going to find out that you should know, actually, that when you have some kind of asthma or such, it hampers your ability to breathe out. Because as you breathe in, your lungs, everything is expanding. So the tubes are expanding. But as you breathe out, everything collapses. So it's harder to blow that air through the tubes that are collapsing than those that are expanding. So we measure how much you can breathe out, how quickly, as a function of how good your tubes are. And so the vital capacity, remember, it's the biggest breath in to all the way the amount of air you can breathe out. That volume of air is your vital capacity. And we'll measure, you really got to tell the people to give it their all, but the amount you can breathe out in 1 second, as hard as you can, how much can you get rid of 1 second? If we see that, that's going to tell you how big your tubes are. And if you breathe out like this, where you can't breathe very much out in 1 second, that's going to mean your tubes are small. They're clogged up, they're bronchoconstricted. So this testing how much you can breathe out in 1 second, if you can breathe out 100% of your air, your total vital capacity, dude, you're in good shape, right? If you can breathe out 70, 80%, you're okay. But if you're breathing 60, 50, then that means it takes you a long time to empty your lungs, and you've got asthma or COPD. So this comparison is FEV1 over FVC is a measure of your tubes and your airways, how fast you can get rid of the air in your lungs. And interestingly, you can take a look at the difference you can tell with this measure between restrictive and obstructive diseases. Because with restrictive diseases, you've got air in your lung pleural cavity. That means your vital capacity is also small because you can only breathe out a little, and how much you breathe out is like that. With obstructive, you may be able to breathe in a lot. Your vital capacity hasn't changed, but obstructive means you can't blow out. So that percentage goes down without really affecting necessarily your total vital capacity. When there's some kind of restrictive disease, that means your vital capacity is less always. So it can allow you to distinguish those. Again, diffusion is how good your gases can diffuse across. And diseases that influence that delicate respiratory membrane can affect your diffusion capacity, right? If that membrane gets thickened, it gets inflamed, gases, oxygen can't diffuse. It takes much longer to go across that distance. When you think about if you have a lung problem, what kind of test do you want to have done? Well, radiography. Get an x-ray. Let's take a look. You can see a lot with that. And if there's something going on down there, you can do a bronchoscope. You can take a bronchoscope down, and not only can you view what's going on in the bronchi, you can take samples down there. You can even do biopsies with this scope. So they're looking at a screen, they're following, they put this tube down through, all the way down, and they can do that. To take a culture, it's not pure because it could be, you could get some mouth bacteria as you bring the scope up, but it is, you can go down and take a sample, you can see what's going on in there. And you can use it if someone aspirates something, if they, sick in maybe during a dental procedure or something like that, or a bug or something, that you can use the scope and say, oh, there it is, and actually retrieve it. All right, let's talk about some diseases. And first we'll talk about a couple genetic developmental diseases. One genetic disease will be cystic fibrosis. And then this alpha antitrypsin deficiency disease is another genetic disease that's going to break down the velar walls. Spend a lot of time there. And then developmental disease, we'll talk about this respiratory distress. And the other name is hyaline membrane because it makes it look kind of like hyaline cartilage because of the respiratory distress causes infection in there. And I'll show you. So yeah, we'll get right to it. So surfactant is a chemical. You think about it, it's anti-surface tension. So it's a fatty substance that has a charged and uncharged region that keeps your alveoli open so they don't stick to each other. What's interesting in pulmonary function, you want the pleural membranes to stick to each other. That allows you to breathe. But you don't want the alveolar membranes to stick together because then in a newborn that doesn't have surfactant, the alveoli stick to each other and they don't want to open up again because the liquid, like two pieces of glass sticking together that are wet, right? They want to stick together. So surfactant coats it and keeps it open. And it's one of those things, surfactant, that develops late in your fetal life. So that's why premature babies have the biggest problems. And if they determine you're a premature baby, they can take a look. They can actually look at amniotic fluid to see levels of surfactant, developed in the fetus. And they can give the mom some steroids that will have the fetus kind of speed up the surfactant. That's one thing. And once you're born, they can get artificial surfactant and blow it into the lungs to try to help too. But it's a cause of premature death. It's going to be usually because you're not making the surfactant. I put up a picture of hyaline cartilage just to remind you what it looks like. It's kind of a glassy look to it, real pretty looking tissue right there. And why it's called hyaline membrane disease, I'll show you a picture, is that all these, the fluids kind of precipitate out into kind of, has this kind of glassy look, filling the alveoli. And that, of course, is going to prevent gas exchange. Here's a picture of it. You guys see this material here is, it's not hyaline cartilage, but it looks hyaline-like. Yeah, I can see that there's a lot of blood, so the vessels are engorged. And so this is a problem of a fetus that is really struggling with this respiratory distress syndrome. So what can you do? Well, you can give them oxygen, like high concentrations of oxygen, but that high oxygen also damages the alveoli wall. So you're really kind of stuck. And so you can see mortality rate, 10%, but just depends how premature, how close to birth you are, really, is what your prognosis is going to be. But early premature babies, you know, it's, the mortality rate is high because, you know, you can't do anything here. You can't get a lung replacement at that young age either. All right. Interesting, back in the 1600s, they noticed that if you, a baby's skin tasted salty, that they weren't going to survive long. Isn't that amazing? And now we know what that was. This is disease cystic fibrosis. That is pretty common. Like 1 in 20 Caucasians carry this gene, carriers, right? But it's not that common. 1 in 20 people don't have cystic fibrosis because you need to get 2 people together that have that recessive gene. So the carriers are fine. But if you happen to get 2 copies from 2 carriers of the bad gene, you've got the cystic fibrosis. And it's a genetic defect that causes a protein that is a chloride pump that really affects the lungs. Your mucus becomes really thick. And the pancreas too, that mucus becomes really thick and you get pancreas problems as well. And your skin, you know, is saltier. And yeah, it's one gene. You don't need to know it's on chromosome 7, but it's a gene that, that affects transporter. And you have this cough. You notice this cough that doesn't go away because you keep making all this mucus that doesn't move very easily. It's so thick. And they would have children, you turn them on their back every day, you would beat their back of their back to kind of loosen up the mucus so they can get rid of it. Now they have machines that'll do that too. But you can see here a picture, you can see a cystosis, these big cysts form. You can see that. And the problem is because you can't get rid of the mucus, you get lots of infections because bacteria will grow in that mucus. And those bouts of pneumonia, you know, even if you take antibiotics each time, you know, to get rid of it, chronic pneumonia is going to destroy the lung. And so you may live, you know, into your 30s or so, but it's really hard on the lungs. So lots of pneumonia is the main thing, always getting infected. And bronchial problems, blood, collapsed lungs, fibers, and then it causes pulmonary hypertension when the lung gets all gummed up like that. It's hard for the blood to flow through. And then also the mucus, it can cause mucus to build up in your sinuses and nasal cavities too. And then because your pancreas is also affected, malabsorption of nutrients, because the pancreas, so many enzymes need to go into to digest your food from your pancreas. Then, yeah. So treatments, you need to clear that thick mucus. It used to be just by beating on the chest. And then you just got to try to prevent those infections. So get immunized and then keep you away from people. So when you have cystic fibrosis, it's a weird thing where you want to make sure you prevent the child from being in contact with people with pneumonias and colds and things, so they don't, you know, keep their environment as clear as possible. They live the happiest life if they're not having those infections. And then antibiotics, of course, you know, and then you know, keeping hydrated keeps the mucus, thins it somewhat, even though it's very, very thick, you know, and bronchodilators, you know. So it was a fact that you wouldn't live out of childhood. And now with all these, with our knowledge and our abilities and antibiotics, we're able to prolong life. But it's genetic disease we can't cure right now, right? All right, so developmental disease and a genetic disease, major ones. So looking at these degenerative diseases, inflammation, why that chapter was so important. We'll talk about infections. We'll talk about pneumonias, COVID, right? And then the next lectures, we'll talk about chronic obstructive pulmonary diseases, non-infectious diseases, vascular diseases. So we'll talk about all four of these categories. But we'll start with pneumonia. Super important, right? Pneumonia, big killer, and cause of morbidity. Basically, it's this. Pneumonia is simply an infection of the air spaces of your lungs. It can be bacterial, viral, even fungal, any kind of infection in your lung alveoli. Consolidations fills them up with fluid and bacteria and your inflammatory response going against that. So lots of neutrophils and macrophages. So you gotta, kill them. You gotta kill that pneumonia. You gotta kill those infectious agents. So pneumonia, we'll talk about, we can categorize as lobar, where infection happens in a lobe of a lung and it spreads in that lobe. Or bronchopneumonia is when you're going to see when bronchioles are blocked off and that region becomes infected, and so it's kind of like scattered, doesn't have to be in a lobe. And then interstitial, also called pneumonitis, is when it's going to be not in the air, but in the walls of the lungs. So this shows a typical pneumonia with those air spaces are filled with neutrophils. You can see the clogging up of these areas. So you're not going to be exchanging gases. Here's a nice diagram showing you a particular lobe can have the infection in it. You can see that on an X-ray that the lobe is infected. When you see broncho, you see this area and the area beyond it. Yeah, it's a little harder to pick this one up. And then interstitial, you can see the area outside the alveoli is being infected. So lobar. This one, usually get antibiotics, take care of it. Streptococcus pneumoniae, this thing lives in your mouth, throat, and you guys. And normally you stave it off, but if you have a low immune system or such, it can grow and it travels to the lungs, grows in there. So you're going to have respiratory distress, fever, leukocytosis, lots of white blood cells. And they can to look at sputum, they can find out you got Streptococcus pneumoniae in there. They do a chest x-ray and they can see, you can see the pneumonia in there. And antibiotics, we have ones that usually work well against the strep right here. And there's a vaccine too. For an elderly person, you might consider this. A really cool x-ray, because see this real solid line? That's the lobe. And then, so the lobes in your lung are demarcated. They have different blood vessels and air that go to the different lobes. And so you can see it spread in a lobe, and you can really tell that. All right, now if there a small bronchus is, imagine it gets occluded, and it could be a cancer growing in there. It could be you aspirate something. Yeah, we'll see people, aspiration pneumonia, people that are post-operative or debilitated or drunk, they don't have, you can aspirate your own vomit. It's a big killer. If you're intoxicated, you got to watch the person or drugs, etc., that the vomit goes out, they don't breathe it in, because in your lungs, then it's gonna, those bacteria will grow in your lungs or kill you immediately if it's gonna clog it up. Anyway, so imagine that it's going to be blocked, and that's going to cause the mucus can't get out of there, and it's going to cause an infection. It's going to grow there. So yeah, so it's a little harder to get rid of. And Legionnaire disease is by a bacteria. Cool story if you like learning about diseases, looking at how it was discovered. It grows in air conditioning and cooling water. This bacteria will grow, and it came about in this convention, the Legionnaire convention. So anyway, but that bacteria we can culture that and recognize that, and like that can grow in your lungs. And so here, yeah, you can see it's not a lobe, it's kind of diffuse. You see these infiltrates in both lungs. You can see it's all over the place. And if it's Legionella, you look at your toolkit, which antibiotic should we use? So yeah, so this one may require several sputum cultures because you're trying to get the infectious agents got to come up, in order to identify it. Other diseases can mask this. The X-ray is not as distinctive, indeed. But it's so important because this pneumonia is a big killer of people that are elderly, bedridden with other chronic diseases, right? And HIV, cancers, pneumonia is a big killer. And so important to find out what that organism is so we can, have the best therapy for it. Interestingly, yeah, I have a picture here. It shows this is pus that's coming. In this case, it's come out of the lungs. The infection is so bad. It's broken through the pleura and it's filling the pleural cavity. Yeah. Empyema. Yeah. It's pus. All right, this interstitial pneumonia, I show a picture here showing it's not going to be in the alveoli, but in the interstitial tissue. And any thickening of that tissue is going to prevent, good gas diffusion. It's usually viral instead of bacterial. So it's infecting the walls of the alveoli. Yeah, and this is for you from your book. You can take a look. You can see that. Lobar, remember Streptococcus. So you're going to have difficulty breathing, fever, lots of white blood cells. This one you're going to see, a single lobe. You can tell in an X-ray looking at that. Underlying condition, sure, very, very elderly or very young. Underlying illness, so you're not moving around as much. You're more likely to get this. And then looking at bronchopneumonia, many, including fungi and Legionella. So a lot of other culprits there that we need to. It's harder to zero in on it. Same kind of symptoms though, same thing, fever, difficulty breathing, exactly. Yeah. And then interstitial, usually viruses. We'll talk about that next guy here next. Walking pneumonia, you hear about this. This one means you have pneumonia, but you're not that debilitated. You can walk around more. You got this weird bacteria, this Mycoplasma pneumoniae. And in bacterial worlds, we got the gram-positives, vancomycin, I'm just against that, I'm sorry. And then gram-negatives, a lot of nasty diseases there are in that group. And then the atypicals. It's a weird one. It's a weird bacteria, but it's one that grows and causes a lot of the walking pneumonias, this atypical. Yeah, and if you have a viral pneumonia, of course, antibiotics are useless. You just gotta rest, supportive therapy. We have some antiviral drugs, but not many. Antibiotics work on bacteria, right? So it depends what kind of pneumonia you have. And if you have pneumonia in a patient, an elderly patient, you gotta worry about them dying. And so you often you want to give antibiotics immediately because if you're wrong, you can't risk the patient's life. But if it is viral, then antibiotics you don't want to give them because not only you're wasting the drug, but you're also encouraging antibiotic resistance. So you want to know if the pneumonia is viral or bacterial. All right, and then lastly here, I talk about TB, tuberculosis. And this is a huge killer worldwide. You're going to see over 1 billion people carry the TB bacteria in their lungs. Isn't that amazing? In the US, we see it, you'll see it often recent immigrants. It is here, of course, we have to look out for it. You'll see active TB patients, but it's a big problem in other parts of the world. Okay. And we have an issue getting rid of it too, because you're going to find out you can be a carrier for tuberculosis. It's called being latent. You've got it in your lungs, but you're not passing it around, and then it can be woken up, and you can become a carrier. So it's hard to get rid of it. Also, the antibiotics we give for the drugs, it's kind of tubers, like in a tuber. It's kind of like in a potato. It's kind of like hidden in this tuber. It's hard to get rid of. And so some of these drugs, you're supposed to take them for 6 months, and they cause other side effects, liver issues and things like that. So people will often stop taking them. And you take half of an antibiotic course, you're just setting up for drug-resistant TB. And so that is a big issue. We have all these we can't get rid of it because people don't take the whole course. And so, yeah, it's a big issue, TB in the world. You got HIV and um, malaria, big issues, and tuberculosis around the world. Yeah, and you'll see here in the US, poverty, lack of access to healthcare keeps it around. Yeah, and you don't have to know all the details here, but I just want to show you is that you can be latent. Look at that. Over 1 billion people are carrying it around. And so it's encapsulated in granulations in your lungs. The bacteria is there, but it's kept at a low level. Your immune system is strong enough to just keep it in these little encapsulated, right? But then you have people that are actively spreading tuberculosis. It's growing, they're coughing, they're getting rid of tuberculosis. Look at that, over 1 million deaths a year, sure, from this. And they can transmit it. And there is a vaccine, this BCG, there's a vaccine that's given in countries where it's a problem. It's not given here, but if you come from a country with a big TB problem, then they really use this vaccine a lot. And so you'll have people here that are infected, and the lesions will not be a big deal, but they'll quickly progress. And the question is, you know, people that are latent, sometimes they'll be reinfected TB, and that will start up all over again. So one of the issues here is that you have latent people that are carrying it, and you're able, if you're immunocompromised or you're old, sometimes it'll flare up and you'll start becoming, actively have the tuberculosis. Looking at the world, you can see this is where new cases are coming about. You see Mongolia, African countries, Laos, and Papua New Guinea and Borneo, and some places, Central America, South America. So you can see, you look at Western Europe, you look at the United States, and Australia, new TB cases are not as big an issue. But here's a map from the 1800s showing TB. So it was, they called it a different name back then. It was a big issue, tuberculosis consumption, killed you on the Oregon Trail. So if you have patients now, if you're looking at patients in the US, like who would you really suspect, would you worry about? You want to do a good history. Obviously, if you've been around tuberculosis patients in the hospital, you want to keep them in negative pressure rooms. You want to make sure you have the proper N95 mask, all these things, because it's very easily transmitted. The bacteria is small, easily transmitted. But if you're looking at, if they're immigrants recently from high incidence countries, they come from areas, you can look these up to see where tuberculosis is a big problem. If they're immunosuppressed, if they even traveled to some of these countries. And then you look at poverty. Are they in homeless shelters? Are they in prisons? These are places where it spreads quite a bit. Yeah, drug use. So there's risk factors that put you at risk for an active TB infection. I took this actually from a cow, but it's a lymph node showing the tubers. Like, it kind of shows that, like, I see the red edges around them, kind of interesting. But this is the bacteria, Mycobacterium tuberculosis. Myco means fungus, so it kind of has this look about it. And then there's a version you get from an infected cow's milk, and that's going to infect your intestines, and it's not transmittable among people. So, but cows and deer can get it. All right, I'm showing these tubers of a potato. So that's where it's named from. It forms these tubers where what happens is the bacteria gets engulfed by macrophages, and then it doesn't die. It actually survives and can grow in the macrophages. And the macrophages, they all convalesce. Remember that granulomas? And that is where it can lay dormant in your lungs. And if your immune system is good, you can eat up all the TB. If you get a dose of TB, if your immune system is good, you can your macrophages can eat them all, and you're not gonna be infected. So usually you're asymptomatic. It means you got TB and you don't know it, but it's in your lungs. Your macrophages have eaten it. They've taken care of it. Yeah. But it can spread. It can spread, and you think about it being a lung issue, but you can have bones, kidneys, can cause infertility in the oviducts, and go spread to the brain. Yeah. So this TB can affect other organs. And usually it's that secondary tuberculosis. So primary, it's your body takes care of it. But then if it's woken up, if it starts dividing where your body can't keep up with it, if you're HIV, you're taking steroids or you're immunocompromised, so you're lowering your immune system, you have cancer, you're taking chemo, is where tuberculosis can raise its ugly head, wake up, and become an issue that will kill you. Yep. And sometimes it's just old age. As you get older, your immune system gets worse. And so the bacteria escape, they start dividing, and you become actively secondary TB. Yeah, and so you're looking at it, once it's in these granulomas, there's people walking around. You show a positive TB test. Yeah, you got TB, but you're primary. And so it's only if you get reinfected or you're immunocompromised that it's able to spread. It's looking at advanced pulmonary tuberculosis. You see it's usually in the apical part of the lung. The bacteria likes oxygen. There's more oxygen up there. And you see granulomas. You see it spreading. You see infiltrates, and it's a big problem. Yeah. And so bacteria multiplying like crazy. That's when a sputum culture will show this bacteria is growing, and it can spread. So how do we screen for this? Well, you guys know the TB test. I bet most of you got this, right? A lot of you have gotten this. They'll do it on your skin. You got to come back 48 to 72 hours later, and they'll see if it's raised. And there's different categories if it's really raised, over 5 millimeters or 4 millimeters or 1 millimeter, depending on the situation, tells you that it's a positive test. And they're giving you actually a little bit of tuberculosis, but it's deadened part, just some proteins from it to see if you've already been exposed to it and you've already made antibodies, you'll have a reaction. Yeah. And you get people, like I say, immigrants, people, they'll be very commonly TB positive on this test. And what does that mean? It means, well, you're carrying it. You may not be able to spread it or anything like at this time, you're not spreading it, but you have been exposed to it in the past. You had a primary infection. To go out to actually prove it, to take the sputum and actually grow it in culture, it takes 6 weeks or so to grow. It's very slow growing. And so now they have better tests, DNA tests that are much more rapid to say, hey, this is tuberculosis. And of course, a chest x-ray, you can look in there and see what's going on. Is it lobar? Is it bronchial? How far is it spread, etc. And here's showing tuberculosis in some lungs. These are granulomas scattered about. All right, there's another kind of pneumonia besides bacteria and viral pneumonia. It's fungal, and you can have some fungi getting in there. You see this a lot, like in AIDS patients when you're immunocompromised. Usually fungi, we don't have that many fungal diseases, but immunocompromised fungi can take hold and grow in this nice environment there. And these things are usually found in birds and bat droppings and dust. So you're an archaeologist, you get a big whiff of dust in this cave, and that's when you really are in danger of getting fungal pneumonia. And there's different types. You guys don't need to learn. You've probably heard of histoplasmosis in the US and other kinds. Aspergillus is a common bacteria that grows all over. But if you get these fungi in your lungs, it can cause fungal pneumonia. And again, primary fungal pneumonia may be asymptomatic. You have it, but it just depends the severity of fungal pneumonia. You can be asymptomatic to be it's growing in your lungs out of control and traveling elsewhere. But again, macrophages can eat the fungus and encapsulate it, and then you just have the primary infection. And this shows, you can see histological section. You can't see it that well in the normal H&E stain, but here with a special silver stain, the hyphae of the fungi just pop out like, oh my God, you've got freaking fungal hyphae growing in all of your interstitial tissue of your lung. Not good. All right, so finally, looking at this, your fungal pneumonia, again, I said it can be minor to life-threatening. And then a tissue biopsy, they can say, oh, look, we can see the fungal hyphae growing in there. And we have antifungals. Medications, they're not great. Shouldn't say that. They vary. So in many cases, if you're immunocompromised, you got HIV, this fungus grows faster than these antifungals can work, is what I'm saying, is that you could have a big issue like that. All right, quite a lot to talk about, I know, but a big killer. So we had to talk about pneumonia and TB, make sure we got all those details. So, all right, long lecture 1. Hopefully this helps you understand pneumonia and TB, as well as premature infants, the distresses they have, a lack of surfactant, and the disease cystic fibrosis. These are the things that pop in that were important in this lecture. All right, you guys, that's it.